Hey, what's up, everybody? Dr. Jeff Moore here. Want to unpack some concepts around the subjective examination as we talk about our clinical reasoning framework and how to really get after these patients in an organized manner that delivers consistent and excellent results over time. So I hope most of you would agree that the magic does happen in the subjective exam, right? So when you're looking at a master clinician practicing, what you often see is a very in-depth, very organized subjective exam that has multiple tiers, and that leads into a very abbreviated physical exam. And the reason that physical exam is so abbreviated is because they don't need to get a lot of additional data at that point, right? When your subjective exam is done properly, you tend to whittle down your competing hypotheses to only a few options, which then allows you in your physical exam to only have to compete against a couple different ideas or hypotheses, which means you don't need to collect a massive amount of data. This is what allows expert clinicians to do the things they do during the physical exam extraordinarily well, right? It's where our concept of doing less better comes from. Doing the front end work of understanding what may or may not be going on, so that when it comes time to actually perform or challenge these competing ideals, you don't have a lot of work left to do. And that's what allows you to slow down, be methodical, and collect excellent information. The novice, on the other hand, practices the exact opposite fashion, right? So a novice clinician will generally have a very short, ineffective subjective exam, and then they will do every special test, right, known to the rehabilitation sciences over a 50-minute period for their physical exam, after which they will be very confused and the patient will be very sore, right? So what we see in that novice clinician is that abbreviated subjective exam in that overly lengthy physical exam, of which nothing is done well and too much is done, period. So I think you'll observe that as you monitor practice over time. We certainly do. Doing less better and really focusing on that subjective is paramount. Now, what's interesting is knowing that we're always surprised how poorly this is instructed in different graduate school curriculums and quite honestly, even in post-graduation Con Ed. So let's talk a bit about doing the subjective exam perfectly. So moving on to slide 2 here and looking at the different components of your subjective exam, of which there are primarily 2. And we need to agree early on that the more separate you can keep these 2 components, the more efficient you're going to be in your examination process. So essentially, there are the story components. What happened, Dave? Right? Did you have a fall? Was there a mechanism? Have you been to the doc? What'd you have done? How'd that go? Right? What happened is the story. The symptom behavior is what are you actually experiencing, right? Where is your pain? Is there any numbness and tingling? Are those 2 pain areas always present together, right? What's going on? How are the actual symptoms behaving? And how is that affecting your ability to run your life? Now, what we find historically is that physical therapists are very, very prone to overdoing the story. We love to get to know people, and I think it is one of the great things about us as a profession, although I do think it gets to a point of being disruptive. And the other part is the symptom behavior, which I think we largely underdo or undervalue, right? So we spend too much time in the history, not in the time in symptom behavior. If you think about it, the reason the vast majority of your patients are coming to see you is to have their symptom behavior altered in a meaningful way. It would greatly behoove you as the therapist then to have the absolute best, most accurate and thorough snapshot of what that symptom behavior is on day 1, because only that is going to allow you to quantify and track outcomes over time, and that leads to buy-in. So spending a bit more time on that symptom behavior is really important to a well-done subjective examination process. Now, looking at a cervical spine patient, neck pain patient, if you will, primary reason for referral, this is what we would consider symptom behavior gathering, right? So we utilize a body chart where we specifically use a cutoff point of thoracic vertebra 8 right here. What we mean by that is when we're gathering somebody's symptom behavior, where is all of your pain? What is going on? Do you have any numbness and tingling? We are really trying to figure out where are these symptoms primarily coming from? What is the primary symptom generator, right? What is the area driving a lot of the nociception that appears to be a really important part of their pain experience? If you think about the way that we are wired and the clinical patterns that you see over time, if somebody has a primary complaint in the upper quarter, meaning their neck, their head, their face, their jaw, shoulders, arms, cervicothoracic junction, if somebody has a primary complaint of symptoms in this upper quarter, it is really only areas above T8 that will likely explain those symptoms, right? So when you think about things that go on below T8, like thoracolumbar junction, what some of you might be calling Main syndrome, right? M-A-I-G-N-E-S, Main syndrome. When thoracolumbar junction gets dysfunctional, it tends to refer symptoms down and around, right? So into the hips, into the groin, etc. Thus, dysfunction in this area of the spine would unlikely be an explanatory variable or the cause of somebody's primarily upper quarter symptoms. On the other hand, above T8, looking at like T4, 5, 6, right, that mid to upper thoracic spine, folks call it T4 syndrome, right? When we have dysfunction in that space, we commonly see referral up into the upper quarter. What a lot of folks see as stocking glove paresthesia in the literature, in what people call T4 syndrome, right? Which, kind of a misnomer because multiple levels in that general area can bring about those symptoms. But due to that autonomic nervous system wiring, we do tend to see bilateral upper extremity stocking glove paresthesia. The point being, above T8, in that T4, 5, 6 region, dysfunction there could very much so explain somebody's primary complaint that is in the upper quarter. So we do need to make sure we're asking about this space. What we probably don't need to do is ask about areas below that, as those would unlikely be explainers for someone's primarily upper quarter complaint. How do we ask about that is quite simple. We tend to say, where is your primary pain complaint? Where does that spread to? What does that feel like? Have you ever had anything over on the other side? What about in front of the arm? What about in front of the opposite arm? Anything at all in between the shoulder blades? And when I say anything at all, I mean current pain complaints or recent issues in that area. So we are going to go through every area, anterior, posterior, bilateral, above T8, questioning for the source of those possible symptoms. We are either going to put a check mark, meaning the person said, no, man, I'm good there. No problems there currently, no problems there recently. Or we are going to write down what they experience, right? Primary pain complaints here. Some numbness and tingling or paresthesia going down the arm. P1 seems to lead to that numbness tingling. Over here, we've got P3, right? Not currently present, but historically has had some issues, right? Functionally not nearly as bad as P1. Here in the neck, right, we had pain a long time ago, occurs commonly. This is actually a real patient. She said to me that she has a bad neck, does not currently have any pain, but certainly has had pain a couple times, as you can see here, over that past year. The point is, we are either going to put a check mark or we are going to write down what that person said as we begin to carve out this very clear picture of that individual's symptom behavior. Now, the history, okay, again, this is where I tend to feel like people do not spend enough time with. We really undershoot our depth of dive into the symptom behavior, which is strange because this is primarily what people are hoping that we can change. When I'm done with this picture right here, I write down my competing hypotheses. So as soon as I'm done doing this, I look at that picture and I say, okay, I've seen pictures like this before. What might be going on? Well, this could be a bilateral mechanical shoulder pain patient, right? Primary complaint is here. This could be a mechanical shoulder problem with some extra-articular or myofascial referral, maybe an active trigger point referring pain into the upper extremity, right? This could be a purely mechanical shoulder issue. It's not unreasonable. I don't know anything about her history. It's not unreasonable she could not have a mechanical shoulder issue on both sides. Maybe she recently started a job where she's using her upper extremities, but she's right-hand dominant, so she's using her right arm a lot more than her left arm, but not unreasonable. Somebody could develop mechanical shoulder issues bilaterally around the same time. Maybe her neck is kind of an old ongoing issue that has nothing to do with her primary complaints of shoulder and upper arm symptoms. On the other hand, maybe the neck's the driver. Maybe this is a cervical issue. We've got bilateral shoulder symptoms. Whenever you think bilateral, whenever you see bilateral, you think central, right? So maybe it's coming from the neck, and maybe this is kind of an emerging radiculitis, right? Maybe we've got a C6 radicular irritation sending pain going down that upper extremity. Very reasonable possibility. Maybe it's both. Maybe we've got some component of neck issue that's been ongoing for a long time and a more recent manifestation of mechanical shoulder issues, possibly brought on by the neck problem or unrelated but both present. Very reasonable. A last one I hope you consider when you look at this is the idea of central sensitization. We've had neck pain for a long time. Now we've got a spreading of this pain map into the shoulder, down the arm, on the other side. Is this somebody that I want to be asking questions about stress levels and maladaptive beliefs and yellow flags? Is it possible that during the physical exam, I might challenge that with 2-point discrimination, laterality testing, pressure pain threshold, heat pain threshold, graphesthesia? Right? Is it going to make sense? I need to entertain that hypothesis until proven otherwise. The point is, from a really well done symptom behavior gathering or body chart, you can form really nice competing hypotheses that you can then challenge throughout the remainder of the exam. And that is really expertise in action. Additionally, this is what helps people get good, right? When you think about your development over time as a clinician, it really comes to how fast can you go from A to C accurately? How good can you get at looking at this and saying, oh, I've seen this a lot before. I know what this pattern is. I know what's helped these people in the past. I know where I should probably start. Now, you got to be careful with anchoring. You still need to entertain your competing hypotheses, but make no mistake about it. The better you get at predicting from these pictures how that case is going to manifest and change over time, the overall better your outcomes are going to be in clinic. Now, moving on and talking about in the actual history, this is where we tend to spend all the time that takes time away from the process of executing here perfectly. So in the history, don't mishear me. Yes, I think we overdo it. I think we spend too much time here. I think this is where a lot of clinical expertise is developed. But there are definitely things here that are very important for that person moving forward well and for you having a really good gauge on what's going on. Number one, getting a really clear timeline. If, like in this patient, you have multiple areas of issue, one of your biggest challenges is figuring out, are these all coming from one thing or are there multiple things going on? Well, the biggest thing that clues you into that is timeline, right? Did they all start at the same time? Or did this person say, oh, I've had this neck thing for 15 years. It hasn't gotten any worse whatsoever in the past few weeks. On the other hand, this just started in the shoulders and down the arm last week when I started a new job. That just initiated. Okay, the odds of those coming from the same symptom generator, considering how different that timeline or date of onset is not very good. So you begin to be able to juggle your hypotheses about what's related to what's coming from what, simply based on that timeline. So carving out really well where things happen, what things might have come together, right, as far as onset is really important to your differential diagnostic process. Now, number two, what have you tried? Right? Important for a myriad of reasons. What have you tried up to this point? Important differential diagnostics yet again. Because if somebody had intervention to their neck and all the other symptoms cleared up, think back to this person's picture. If this individual had intervention to their neck, maybe that's an injection, maybe that's cervical manipulation, or maybe it's massage, and they said, oh, when I had my neck treated, all my symptoms went away. Again, your hypothesis that these things are connected and perhaps even that the neck is driving all the other symptoms begins to strengthen or elevate. Whereas the fact that it's mechanical shoulder as the primary underlying pathology or etiology, the odds of that are now going down. So you knowing what they've tried, where it was tried, and what the outcomes were does a lot from a differential diagnostic perspective. Additionally, maybe more importantly, if you really zoom out and read all the research, the more you understand about what they've tried and how that's went, the insight that gives you into the patient expectation is so valuable, right? So when you think about other things helping, right, or not helping, if you can incorporate things the patient felt were helpful and avoid things they felt were harmful, leveraging that patient expectation is going to have a lot of merit inside your plan of care. So when that person says, right, when that person says, I had intervention to my cervical spine, right? I had the chiropractor crack my neck, and boy, did that ever help, right? That person who's presenting with primary complaints of neck pain. You've really got to consider incorporating some manipulation. On the other hand, when that person says, well, the thing that I have tried, right, really was not very useful, right, really made me worse, sent pain down my arm. When I tried that manipulation, when I tried that massage, when I tried whatever that intervention was, that was the day things really went downhill. I would strongly encourage you to steer away from that intervention in your patient client's early part of their plan of care. Now, that doesn't mean that they get to drive treatment entirely, that they get to dictate what it is you do and don't do. It just means in a shared decision-making approach, you are going to leverage things the patient has a positive expectation for, and you are going to intentionally avoid things the patient has fear of or a negative expectation for, especially early on as you're deepening your therapeutic alliance and as you're making those initial few jumps towards recovery that elevate expectations to such a degree. So understanding what the expectations are, right, what they've tried and what the outcomes were, gives you really nice differential diagnostic information, as well as really helps guide your plan of care because you understand expectations. Obtaining a clear timeline, very, very important. Treatments attempted and results, very important. Getting in their head, very important, right? Always saying, what do you think is going on? And I know that people are like, it's hard to say that because the patient always says, well, aren't you supposed to know? Don't put your gloves up on that. That's a wonderful follow-up question. Our answer is simply, I've got a lot of ideas on what's going on, but it's not like your ideas don't matter. Your ideas are very relevant. You've been Googling, you've been going to the doc, you've got some questions, you have some ideas, conceptions, you've got family that had similar issues. You have a lot to bring to this process. It's very important that I understand what you think is going on. You're the one living in there. I think that is an extremely refreshing thing to hear as a patient in this medical system, that their ideas matter, right? What they think matters. I can't come get you and walk with you until I know where you are. We're going to do this together. Your ideas are critically important to this process. Just letting them know that is such a massive positive shift on day one. Obviously, at the end of the history, always recapping, right? Did I hear all of this correctly? And is there anything else at all you want to add? So these are really the very key things that you need to be capturing during that patient history. This is what you need to be capturing during the symptom behavior gathering. Importantly, we keep these two things separate, as I mentioned earlier, to maximize efficiency. The question then is, if we keep them separate, and now we know how to do them, and we know what they entail, which one of these should I do first? And that's really the critical question we want to challenge you all with, because it's really the organization of this objective that drives the excellence of it. Now, most physios will tell us that they like doing the history first because they get to know the patient, right? The patient wants to be heard, right? These kind of things. Those are very well-meaning things. We don't think they are the best things to use to guide this process. Patients don't want to be heard. They've been heard. I think we underappreciate that, right? Patients have generally told everybody they know the story about their neck pain or their back pain. They've certainly told their spouse. They've certainly told their friends. They've been heard a lot of times. What they have not been heard is well. And this is really, really important because it's not just our job to play the role of another active listener, to be this person's buddy. It's our role to create a situation in which hypotheses are best formulated and most effectively challenged. And that does not come just from letting somebody rattle off their story, right? And think about this in real time in clinic. Let's go back and pretend this is your patient. If this person comes in and they probably have a referral for either neck pain or shoulder pain, right? Let's say they have a referral for shoulder pain simply because in real time, in my real life, this person actually did. So person comes in and they've got a referral for shoulder pain, right? If you allow them to go into the history first, it's going to sound something like this. Tanya, what's going on? Like, tell me a bit about what happened, right? And Tanya's going to do exactly that. She is going to launch into this story that she has told a million other people already of which you don't have enough bearings. You don't have enough known variables to create a roadmap to really make any sense out of this story. You're just the one more person who has listened to this story over the past few weeks. So Tanya's going to launch in and say, it was a few weeks ago, Doc. I turned my arm really funny in the car. I reached into the back seat. I felt a bit of a yank in my shoulder, and boy, it's been a problem ever since. I went into the doc. I got an injection that seemed to help quite a bit, but it didn't go all the way away. So I actually went and got a massage, and I thought that was valuable as well, right? I actually did have almost complete resolution of symptoms following the massage, but you know what? It came back. So when I went back to my doc, he ultimately said I should come to you. We did some imaging. On the imaging, we found yada, yada, yada. You all get the point. This patient is going to talk at you for several minutes, 5, 6, 7 minutes, all the while of which you're primarily just nodding at the patient, right? You're kind of sitting there. Don't get me wrong. You've got open body language. It's a very therapeutic encounter. They very much feel listened to, right? You're sitting there kind of going like this. What you don't have is a lot of relevant follow-up questions that drive either a differential diagnostic process or lead you towards what might be the number one intervention to actually be able to help this human. The reason you have no ability to do that is you haven't formed any hypotheses before the story began. Not only have you not formed hypotheses, you're not challenging competing relationships. You're really, with all due respect, not doing much of anything besides letting this person talk at you for a while. To prove that, think about doing it the opposite way. Think if Tanya came in and as you walked into the waiting room, you said, Tanya, can you show me, before we jump into your story, can you show me exactly where you're having symptoms? And imagine this winds up being her symptom behavior body chart. Well, it's primarily, Doc, in my shoulder, but more recently I've had this going down my arm. Historically, I've had some neck issues. I actually do have this bilaterally, by the way, but I only told the doc about the right shoulder. The left one's really not all that bad. And you're going to carve out this clinical picture before you take this person's history. Can you begin to appreciate how different your history taking is going to look and sound? Tanya, once this is done, your competing hypotheses formed, it's going to sound like this. Hey, Tanya, so take me back. You said this shoulder's your primary complaint, right? When did this start? Well, it started a few weeks ago, Doc. I was in my car and kind of reached back in the back seat. I felt a funny feeling in my shoulder, really gave me kind of a zinger. So I went into the physician and I got an injection, and that really seemed to help. I hope you appreciate that if you have done this symptom behavior first, you have formed competing hypotheses before you've heard this story from Tanya, one of which is cervical involvement. Thus, at the moment the patient tells you they got an injection, I would hope that your immediate interjection would be, ooh, Tanya, 1 second. I guess I'm curious. I'm not entirely sure yet if we're dealing with a shoulder issue or a neck issue. Can you tell me where you got that injection? Now notice, if you did not have this on board, if you had done the history first and assumed the shoulder was the primary and perhaps exclusive pathology, you never would have felt the need to ask about the location of injection because you would have assumed it was in the shoulder. Having done this first, having competing hypotheses to challenge once against another, you are now asking these very critical, important follow-ups, interjecting at key points in time with the next most important question to figure out which one of these is driving. Not only are you going to say where, and perhaps Tanya says, I got the injection in my shoulder. The next question you're going to ask is, and you mentioned it got better, what got better? Another question that without this information, you never would have thought to ask because for all you know, she only has shoulder pain. But armed with all this information of where all the symptoms are, your competing hypotheses of what might be driving which ones, you are dying to know when you got that shoulder injection, what symptoms changed. Because if Tanya says, oh, all the shoulder pain went away, you're going to say, only the shoulder pain? Tanya, what about this? You know what, Doc? That didn't change at all. The injection felt great in my shoulder, but yeah, there was no change whatsoever of that pain going down the arm. Your hypothesis now that there is likely some issues going on in the shoulder, but there also might be something else going on, perhaps an emerging redic simultaneously, is being strengthened. right? So again, you asking, where did these interventions happen? What exactly changed following the interventions? You would never think to ask these things, nor could you do them in a clear, educated fashion unless you had this image on board first. It is our contention that a properly done body chart in differential hypotheses or competing hypotheses being formulated prior of the history being taken is one of the foundational pillars of clinical excellence, particularly during the evaluation. This process, poorly done by most physios, is an absolute game changer. There are so many positive sequelae of this process. I'll tell you one of them right now that no one gives enough credit to is your mental health. As the practitioner, sitting and passively taking on stories all day of people who are having a hard time is exhausting and a sure route to burnout. Sitting there saying, well, tell me more about it. And how was that? And how was that? You're not actively thinking. You're not differentially diagnosing. You're not involved in this process. You are just passively taking on one challenging story after another. It is so different when you already have competing hypotheses and everything the patient says is shifting you towards one or the other. It is a puzzle taking place in real time. Every question you ask is like flipping over one more piece of that puzzle, right? Ooh, where was that injection? What symptoms changed? Where did the chiropractor treat? What did the massage therapist work on? When they did, what was bothered? What was eased? You are so curious because you're trying to solve this puzzle. Can you imagine how much more fun that is for you? Can you imagine how much different that feels for the patient? Somebody who's on the edge of their seat, ready with the next question, wanting to learn more about it. You can see their wheels turning in real time. Can you appreciate how much this deepens the therapeutic alliance? How much more accurate this makes your process? And how much better this is for your mental health? Give those factors some serious consideration. Here's the real rub. You're going to do it this way no matter what, right? Like if you think about it, you're going to do it this way. The question is, are you going to do the history twice or are you going to do it right the first time? Because as uncomfortable as it may be to bring up, if you don't do this body chart and you assume it's a shoulder problem and Tanya gives you her 7-minute spiel, of which you are nodding and active listening but doing little else. When it's over, I'm assuming at some point you're going to say, by the way, Tanya, can you show me exactly where you're having symptoms? And this is where the moment of dread occurs, right? Because this is where the patient says, oh, well, like I said, it's in my shoulder. More recently, though, it's been going down my arm as well, and I've always had a neck thing. That's the uncomfortable moment in clinic where you've now got to say to that patient, okay, Tanya, this might not be as straightforward as I thought it was. Honestly, a lot of these symptoms could be coming from your shoulder or your neck. Can we go back into your history? You had mentioned that you got an injection. I was assuming that was in your shoulder, but I guess now I'm not so sure. Was it in your shoulder or was it in your neck? By the way, whichever one it was, afterwards, you mentioned it got better. Well, I didn't know you had all these issues. Did both your shoulders get better? Did your arm get better? Was it only your neck? What exactly changed following the injection? Now, team, we always say at ICE that excellence looks different. Excellence does not look like going back and redoing somebody's entire history because the first time you had no idea what to ask. And believe me, it feels different to the patient. There is not a patient on the planet who isn't thinking, didn't we just do this? Why didn't you ask me this the first time? And the uncomfortable truth is, I didn't know what I was doing the first time. I was just hearing you out. But now I've got to really go back and do my job, and that involves all of these next most important questions. Crew, it is going to save you 5 to 7 minutes. It is going to make you more efficient in clinic. But far more importantly in our mind, it's going to protect your mental health. It's going to dramatically increase your level of engagement, which is going to deepen your therapeutic alliance. It's going to demonstrate a level of excellence and expertise by being efficient, by doing things once and doing them well. The patient's going to recognize that's going to elevate their outcome, right? Because when expectations go up, so do outcomes. We always say at ICE, No barstool stories. I love that expression, right? I bartended for years, right? People used to mosey in. Hey, Dan, what's up, man? What's going on? What's shaking today, right? Tell me what's up. And I would largely passively listen, right? That was a great part of my job. I love that part of my job. If there's a jam in this world for me, it probably involves something like that. But this isn't that job. This isn't hearing somebody out. This is giving them your absolute best expertise by differentially diagnosing and hanging on every word they say to most rapidly come to the clearest conclusion. And that is not accomplished by sitting next to somebody on a bar stool and letting them drop the same story on you they've dropped on every single other human they know. So give that some real good thought. Let me know if you have any questions. jeffmooredpt@gmail.com. You all know where to find me on social media. Hope you're enjoying the course. Thank you so much for listening.